Todo mundo sabe o que é tradição, mas ninguém sabe quando ela nasce. Harvard levou 140 anos para virar universidade. Mas os tempos mudaram. Hoje, tradicional é procurar na internet. Há 20 anos, era na enciclopédia. A tradição agora é usar o WhatsApp. 6 anos atrás, era o SMS, lembra? Hoje, para construir um legado, você não olha para trás, e sim para frente. Porque tradição é mirar as próximas revoluções da medicina. É ter professores que são referência em todo o Brasil. É usar tecnologia para inovar no método pedagógico. É ter parcerias com instituições de ponta, como Stanford e Emory. Tradição é formar agora os profissionais da medicina do futuro. Medicina Fazer, nota 5 no MEC. Fazer, nasce uma nova tradição.
All right, so good evening, everybody. Hello, good evening. Yeah, everybody's there. All right, so we have today our last day of our second international symposium of global health, emergent and re-emergent disease. So I want to thank you all for coming. I know it's a long journey, so the third day, a lot of topics were discussed here. I want to thank Dr. Ricardo Guimarães, our president, is here and has been enthusiastic with all of these opportunities for discussions and collaborations. I want to thank you also, my colleagues and friends from United States. Thanks for all the efforts for being here and contribute so much for this conference, and not only for the conference, but also for the FASE educational and research programs. I want to thank you especially today, Dr. Lucia from Universidade Federal de Juiz de Fora. Professor Lucia is one of our collaborators in Hansen's disease, and she's a full-time professor at the Federal University. Thanks, Lucia. She arrived this morning, and she will leave tonight back to Valadares, so came just for the symposium tonight. Thank you so much. And also our friends from Federal University, Dr. Betani is here, will give us a fantastic lecture about yellow fever. She has been working deeply in this issue here in Minas Gerais, so it will be amazing to hear about what she has to say. And of course, thanks to all students. You are the reason, again, I insist on this idea that you are the reason for this international program at FASEM. So thank you so much, and hopefully you enjoy the evening and all the themes and issues that we'll be discussing tonight. So tonight we'll be starting talking about public health. So we invited Dr. Michael Maurer from University of Miami, and he'll be talking about universal health coverage in pediatrics, concept, progress, and challenges. So please welcome Dr. Michael Maurer.
All right, this is much more comfortable. Hi, everyone. Thank you to everyone for coming again tonight. I know that I've seen some of you guys here all 3 nights. I know it's not easy to get here from way out in Vespasiano every night, so thank you to the students and everyone else for coming. It's really an honor to be able to present to you guys tonight. Also, I want to say hi to my YouTube fans. I know that we're on video tonight, so this one's for you. Tonight we're going to talk about something a little less specific than last night. So last night I talked about a lot of really complicated immunology, and it probably still doesn't make sense to you. It doesn't make as much sense to me either, but that's okay. But tonight we're going to talk about something much more broad. It's universal healthcare in pediatrics. I think it'd be very difficult to find people that would advocate that children should not be covered for healthcare, and so I think there's the general consensus that it's important to be able to provide healthcare and medical care to our children. But we're going to go a little bit more in depth into this topic tonight. Again, I have no financial disclosures. This is a very big, overarching, relatively basic talk that we're going to be going through tonight, but I am going to try to be as non-political, nonpartisan as possible. I know that healthcare in particular is a very big topic when it comes to any sort of political parties and any sort of elections. Tonight, I'm just trying to lay out a lot of facts for everyone and to sort of bring about what my thoughts are in particular, not related to any particular political affiliation. So our objectives for tonight are the first one is to understand the current state of child health worldwide and locally, to review the progress made in child health worldwide and locally, and then to discuss the challenges with providing universal care to children and ideas for improvements in child health, which there are a whole lot of those. So I found this funny little cartoon, which I think speaks volumes to this idea of healthcare coverage, universal coverage versus access. And so there's a lot of discrepancy between the concept of universal healthcare coverage versus actually having access to a healthcare system. And so this looks like, it's a big maze that we're seeing. And it's like, oh, we have universal access, but really trying to maneuver these different healthcare systems can be a very big challenge for healthcare providers, as well as and most importantly, for the patients and their families. And so this is just a little lighthearted way to kind of look at how big of a challenge this problem really is to be able to provide healthcare access, healthcare coverage, providing really quality medical care to kids that need it. So what I want you guys to really think about over the course of this presentation is the whole concept of access to care. And really the big question I want you to think about of what does that actually mean? What does it mean to be able to provide access for a patient to be able to get care? I want you to think about why that matters. And then does increasing access actually have any impact on healthcare outcomes? Does it even matter? Or are we all doing this just because we want to say that we're doing something to help children, but we have to know if we're actually helping kids or not? Of all of these questions, I think that one is a lot easier to answer, and that's going to be the why does it matter? And so we're actually going to start with why does this topic matter? Why are there so many big discussions about this when it comes time for elections? Why is access, and universal access in particular, a topic that we even need to talk about? So we're going to talk very much on a global scale tonight, because I think that that's what is most important, being that we're at a global health symposium. And so I wanted to show you some statistics. And so this is looking at global mortality rates for children under the age of 5 years old. And so what we've noticed when it comes to child health on a global scale is that this 0 to 5 years of age is really important for kids. And if a kid is going to die, this is the most common time when that's going to happen. And actually we see it happening more in the first month of life and then the first year of life, and then it sort of goes down from there. But we've put in a lot of time and effort into this 0 to 5 age group. And so I wanted to point out is that the top blue line is actually the 0 to 5 age. And so looking back from 1990 to 2017, we went from about 90 per 100,000 live births as a mortality rate down to about under 50. So we're in the lower 40s, lower to mid 40s at this point. So doing pretty good. The dark blue line is our infant mortality rate. So that's kids under 12 months of age. And then the black line on the bottom is the neonatal mortality rate. So if you look, all of them have gone down. The neonatal mortality rate has gone down less so and less steeply than the under 5 rates. And so we're seeing a lot of big challenges still in that 0 to 1 month range for a variety of reasons. But this is what we see on a global picture. So this is what has really happened over the last 25 to 30 years, which we've made pretty good strides in cutting our mortality rates in less than half across the globe. So what has happened in Brazil? So Brazil has actually done a really wonderful job. So if you look back in 1990, there were about 64 deaths per 100 or per 1,000 live births in the country of Brazil. And then fast forward 27 years, and Brazil is now at 14.8 per 1,000 live births. And so you've actually had a very, very big drop here. And so many of you are probably a lot more familiar than I am with the Brazilian system. But I know I sat in a lot of lectures last year when I was here where there have been so many initiatives looking in this 0 to 5 age range within Brazil, really looking at the perinatal care. So looking at being able to provide resuscitation in delivery rooms, being able to take care of children in the NICU afterwards, and really helping in that 0 to 1 month range. And then I also had the great opportunity last year to actually go out and do a lot of our home visits. And so the home visits through the SUS program are amazing through the PSF system, because they're actually going out to the homes in these very rural communities, and you're actually getting to do developmental evaluations in the child's home. And so you can see if kids are sick. You follow up the chronic kids very closely. The healthcare workers that are going into these communities are making a huge difference. And so Brazil has seen a much larger decrease in their mortality rates compared to the globe as a whole. And so there's been a lot of work done in Brazil, but there is still a little bit of work to be done. And what happened in the United States? So the United States actually started at about 11.2 per 1,000 live births back in 1990, and dropped to not quite that 50% range, to 6.6 per 1,000 live births. And so the U.S. kind of followed the global trends, but sort of started out in a little bit of a better position. And we see a lot of neonatal deaths due to a lot of congenital conditions, and some things that preventing these neonatal deaths is going to be pretty difficult to achieve for some of the kids born with these really fatal genetic conditions or other congenital malformations as well. But we definitely still see kids dying from different birth traumas and things, which we'll talk about. So overall, what we've seen is that there are about 17,000 fewer deaths in children under 5 years of age per day now compared to in 1990. So we've made really significant improvements in helping with our child mortality in less than 5. However, we still have 15,000 kids dying worldwide every single day across the globe. And so this definitely is still a problem, and it's a main point of a lot of our larger governing organizations across the world, like the WHO, the United Nations, which we'll speak about a little bit. And not only do we have kids dying, the question is, well, Brazil's doing great, US is doing great. Where are all these kids actually dying? Do you guys know where these kids are dying? This is going to tell you where these kids are dying. So if you look at this map, this is sort of the geographic distribution of child mortality rates. And so what we see now is that there's a really big disproportion of deaths happening in sub-Saharan Africa. And so basically what we're seeing is that there's this really large disparity between a lot of other countries in the world and what we're seeing in sub-Saharan Africa. So these advancements, and so while we've seen great mortality rate improvements in a lot of countries, we haven't seen those same improvements in a lot of these countries in Africa. So there's a really large problem that we're seeing, and it's mostly now related to disparities between a lot of developing countries and more developed nations as well. So 4 out of every 5 deaths under the age of 5 years happens in sub-Saharan Africa. And so this problem is really localized on a global scale in child health to these particular countries. So I'm just trying to put this into perspective of where the problem is predominantly located. So you might be wondering, okay, so that's kids less than 5. What about the other kids, right? So not all of children are, under 5 years of age. What happens after 5? And so we see the same sort of clustering of mortalities in these same countries. The numbers are way less. So the highest is really 30 per 1,000 children, whereas before we were looking at areas where greater than 100 per 1,000 kids under the age of 5 are dying before their 5th birthday. So that's more than 1 out of every 10 kids. It's pretty significant, you guys. But when we get above the age of 5, we still see this clustering here in sub-Saharan Africa, and the rest of the countries do pretty well helping keep kids and teenager relatively healthy, or at least alive during that age group. The next question that I really have is, well, then what kills all of these kids? Why are kids dying overall? And so if you look at how it's sort of spread out, is the orange is the postnatal period, so 1 month through 6 years of age. The blue is our neonatal death, so in that first month of life. And so there's a very large proportion of under 5 deaths happening during that first month of life. So neonatal mortality is still a very large issue. But if you look closely, I don't know how well you guys can actually see the PowerPoint, but if we're looking at the most common causes, about 1.5 million deaths annually are happening due to prematurity or some sort of birth trauma and birth asphyxia. And so we're really looking at a lot of prenatal care contributing to this, as well as ability to do resuscitations or ability to have safe and effective delivery, C-sections, other types of antenatal care as well. But if you also look at all of these ones in the green boxes, so we have acute respiratory infections, diarrheal infections, meningitis, measles. Down here we even have HIV and AIDS, some other communicable diseases. a lot of these things that we're seeing, and when we compare that with prematurity and birth traumas, we actually see that these are a lot of very preventable conditions. And so when you're really young, you haven't gotten all of your vaccinations yet. So we can't really vaccinate before that, that couple months of age. But those aren't the reasons why kids are dying in less than a month. They're not dying from measles when they're under a month of age. They're dying from measles when they're a little bit older, as well as these kids that are dying from HIV and AIDS, which we already know that if you treat mothers during pregnancy, that the risk of transmission to the baby is super, super low. So that's sort of the big idea behind all this, is that most of what still is killing kids are things that are preventable. So these are some graphics these are very rough estimates. So this is not actual data that's been gathered. These were they took some data and extrapolated it to make these graphs. And so this is, say, the total amount of kids that die each year, 5.4 million. And so if they did this regional if you put all of the countries sort of in the same geographic region into a scale, and you use the best mortality rate in that region, and you put all of the countries in that way, we'd only have about 1 million child deaths under the age of 5. And then if you compare it with the best mortality rates in the whole world, we'd only have about 300,000 deaths of kids each year. And so it's really looking at how can we really start to level those disparities, or actually erase those disparities completely, get rid of these disparities that exist, particularly in our sub-Saharan African countries. So this is sort of a big problem. So that gives you a very large background into this idea of why is universal access to care important for kids? Why is universal coverage important? It's because a lot of these things are preventable. But with such a big problem, it kind of leaves me thinking, like, what am I looking at? Why am I here? You might feel a little bit like Dorothy in Wizard of Oz when she's in this sort of like area we don't know, because most people have never been to sub-Saharan Africa. We don't understand exactly what's happening in a lot of these different countries. And so we're not quite sure exactly what to do. Well, thankfully, I'm not the first person that's thought of this idea. A lot of really smart people have actually thought of this idea long before I did. And so what have we done about this so far? So if you go back to 2000, the United Nations signed a large agreement. All the countries in the UN started a huge agreement called the Millennium Development Goals. How many of you have heard of the Millennium Development Goals? A few of you, great. So there were two of them in particular that really focused on our kids not dying anymore. So number 4 was actually reduce child mortality. So that was the biggest goal right there. And then number 5 was improving maternal health. And so we saw a lot of really big successes over 2000 to 2015. So again, we decreased under 5 mortality by over 50%. We also decreased neonatal mortality from 33 to 19 per 1,000 live births, which is great. And then the measles vaccination was actually implemented in a lot of places. And so we reduced a lot of our measles deaths as well, which is a pretty important part of this process as well. But we weren't quite exactly where we wanted to do. And so what happened in 2015? Do you guys know what we did in 2015? We created something called the Sustainable Development Goals. And so the United Nations got together and they said, well, we made a lot of progress, but again, 15,000 kids are still dying every single day, particularly in the sub-Saharan African countries. And so we really need to do more about it. If you look at this, we have 8 really big goals. And I think these were set out really as this like eye in the sky type of goals of look at these big overarching themes. And so we wanted to get more into this idea of sustainability, because with climate change and with a lot of other environmental issues that our entire globe is at risk right now. And so they expanded this a lot more to many other goals. And so now we have 17. And there's really only a few of these, no poverty, zero hunger, quality education, those definitely factor into child health overall, but there's only one that really says good health and well-being. And so to me, that's a very general term, but they really extrapolated a lot more into this and went into more detail. And so these 3 in red are the most important parts of this entire goal number 3. And so I'll read these aloud to you. So 3.8 is achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. Not for some, for all is really the goal. And our goal is to do this by 2030, by the way. And then the second is supporting research and development of vaccines and medicines, making them more available, and then substantially increasing health financing and recruitment, development, training, and retention of the health workforce in developing countries, especially in the least developed countries and small island developing states where we see a lot more of these child deaths, like in sub-Saharan Africa. So this is sort of the big global picture of these really smart people, really awesome people that have great intentions, are wanting to make a huge difference, and we're doing it through these sort of big United Nations initiatives like the Sustainable Development Goals. So now I feel like we have a better understanding of why does this matter, and so I kind of want to go back to what does it mean? What does access to care mean? And so we're going to look at that very briefly. So the World Health Organization sort of divides access to care into three large pillars. And so the first one is physical accessibility. The second one is financial affordability, and the last one is acceptability. And so we'll talk a little bit about what each one of those means. But this is where I apologize. Last night, I really didn't have much audience participation during my talk last night, and I love hearing what your thoughts are, because we have a room full of incredibly bright, brilliant minds sitting here, and I like hearing what you guys have to say rather than just having to listen to me blabber on about things and think that what I'm saying is right. So we're going to talk first about physical accessibility, and I'd love to hear what you guys think might be some of the big issues that go into this category. So if this is one of the three main tenets to access to care, what are different components of this that some of you could come up with? I'll give you one. Proximity to services. So just having a clinic within the location of where you live. This is still a large problem in a lot of places. And you guys actually see this here in Brazil. We see it in the United States of people needing to get to a subspecialist for different reasons, or even people that live in very rural areas that don't even have access to a primary care physician. They maybe have to drive 45 minutes or an hour on the highway just to get to a primary care physician, and they don't have an emergency department anywhere close to them that has something like trauma services, or some of these bigger issues. What are some other things that you guys think might contribute to this physical accessibility? Yes. Transportation, great. Is that number two? Yeah, nailed it. Um, so transportation is huge, and so there are actually that was great. I don't know how you knew that was coming. Anyways, transportation is a really, really, really big issue, and so I've heard some incredibly just like earth-shattering, heartwarming stories of people that take 7 buses. They spend 4 hours just to come to an appointment. They show up to their appointment 2 hours late, and they're like, "Do I still get to be seen? I spent all day trying to come to see you, and I'd really like to have that opportunity." So transportation is a huge barrier, and in the United States in particular, we do a relatively decent job of covering most of our kids in the United States, but so many people live very far from a subspecialist that I have a lot of kids right now that I work with that have diabetes, but the only endocrinologists are actually in downtown Miami, and we don't have any pediatric endocrinologists out in the remote areas of Miami-Dade County, and it takes them 2.5 hours by bus, where they have to pay for 2 bus tickets plus the 3 other kids that the mom has to take care of during the day just to get down to a subspecialist appointment. And so families aren't able to access care. So transportation is actually a really, really big issue. Any other ideas? What are those mumblings? Well, I have a few more. So available clinical services. So it's one thing to have a clinic that's close by, but it's another thing to actually have maybe the subspecialist that you need to see, or maybe being able to get the imaging study that you need done, or having the laboratory test performed that really needs to be done for you to really see if you're able to get those care. So having available clinical services is really important. And we talked a lot yesterday about the issue with neurosurgery across the globe, and it's not just about having a neurosurgeon there. It's about having an entire team of people, from social workers to mental health workers to the nurses to the respiratory therapists to pain management to infection. I mean, we have to have a whole team of people in place to be able to deliver really quality care to a lot of people. And so that's another thing that we'll talk about, is not just having care available, but having quality care available that the patients truly deserve. Disability access. So a lot of people are disabled and have trouble ambulating, or maybe are in wheelchairs, and this kind of ties into transportation. They might not be able to drive, and so being able to get to their appointments is quite difficult. And then the quality of services offered, as we just kind of alluded to, and then medication access. And so not everyone has equal access to medication. Some are very, very expensive, and thanks to our lovely pharmaceutical companies, some things just haven't become generic yet, and they're quite expensive. When it comes to financial affordability, the idea behind this principle is really to be able to give patients the ability to pay, but actually not making those medical bills a burden or creating financial hardship, which is a really difficult task, because some things that we charge for are really expensive. Getting an MRI, getting a CT scan, getting some of these procedures performed, having a surgery of any sort can be really expensive. I know when I look at the list of how much a medication costs when we administer it in Stanford. It's like Tylenol's like $100 or something. It's outrageous, the things that are being charged by some of these different institutions, and that happens globally. And so we really want to find a way to not create a financial hardship for a lot of our patients and their families. And then you think about medical insurance plans and medication costs, and so there are a few different ones. And I think we learned about a really good one last night, the Kaiser plan, that has really helped a lot of workers, millions of people in the United States. But trying to find an insurance plan that's going to be able to cover kids in a really effective way, and trying to lower the cost of medications, particularly if there's a certain medication a kid really needs, but it might be $10,000 per dose. And so being able to really subsidize that for the family so that it doesn't completely make them bankrupt. And then acceptability. So this is I'm plus minus on this concept, but I understand the importance, and I get why the World Health Organization put it in, because when you think on a more global scale, there's a lot of cultural implications that go to healthcare. And so when it comes to trying to implement either modern medicine or integrative medicine between Eastern Western medicine, or more homeopathic or traditional medication regimens, it's really important that the patients feel comfortable coming in to see their physician. And so one of the larger reasons why many patients don't seek care is because they partially don't know that they're supposed to, and they don't know that they need to, because they don't realize that there's something wrong, that they might be sick. They take something for what it is, and they aren't sure that there's an actual medical issue going on. So it's this willingness to seek services. It's the impression that the services are going to be worthwhile and helpful. So if a patient thinks that, oh, that doctor is horrible, I'm never going to go back there, then they're not going to seek care. And if that's the only physician that they have within a 100-mile radius, then they're never going to go to seek care, and they're just going to continue suffering, and they're not going to receive the healthcare that they need. And so we have to work to create this impression that the services we provide are helpful and worthwhile for our patients. And then the whole community in general needs to really recognize it as something that's beneficial to the community, something that the entire community is able to benefit from. Because if there's not community buy-in about providing healthcare services, then there's not going to be a really big push to be able to bring in a lot of the things that are needed. There are so many other things that contribute to child health. And when we look at those mortality rates, when we look at the children being sick across the world, these are just a few of the things that popped into my mind. And as I was doing a lot of research in this topic, these are very common themes that I ran into. Things from immunization programs to medical education and training. If you saw in the Sustainable Development Goals, it's really trying to create this healthcare workforce in a lot of these sort of underrepresented countries or really underserved areas, to trying to create healthcare professionals that are going to be able to provide not only just some care whatsoever, but quality care, effective care that's going to make a difference. Prenatal services. This is one of the largest areas that there's a lot of work and research going into, of trying to improve maternal health and trying to improve that time during pregnancy, so that there's a smooth transition from the prenatal to the antenatal and perinatal period. Health literacy is huge, and health education. So a lot of our patients come from maybe very rural or indigenous backgrounds, and just have a low understanding of healthcare in general, and a more modernized healthcare system. And so we have to try to help educate as much as we can every time that we meet our patients, to help them feel a little bit more comfortable with what they're going through. Environmental concerns are quite important. Sanitation and clean water. I'm sure Desiree sees a lot of this when she's doing her work in Africa, and she presented an entire lecture yesterday. Was that yesterday on trash? 2 days ago on trash? Whenever. So what? Yeah, and violence definitely goes in here. And so when we look at sanitation, trash is this potentially huge driving force for these different arboviruses. And so we really have to think about clean water and sanitation. I actually sat on, I listened to another very interesting lecture about a year ago, by somebody that was doing really interesting work on hand hygiene in sort of rural areas throughout, I forget where she was. I think it was somewhere in Africa that she was doing her work, and just looking at the transmission of all of these different soil diseases. Just watching kids play on the playground and then go touch their drinks or go touch their parents, or however, and just looking at how these diseases are transmitted from some of these different infections. Medication availability. And so it's one thing to have good costs of medications, but it's another thing to be able to offer them. Public health initiatives, which is a very broad topic. Policy and advocacy, which is something that's becoming, to me, very increasingly important. So I moved from a state that had expanded our largest insurance insurer for kids in California to a state that does not cover all kids when they move there. And so I've been working mostly with uninsured patients now and have become a very strong advocate for children, particularly where I live. But one that I want to talk a little bit about, because I just feel like we can't have a discussion about child health and outcomes without talking about maternal education. And there are so many different studies that have proven and demonstrated that increasing the education of a child's mother is going to have healthcare benefits and outcomes, both short-term and long-term for that child. And this is it's really one of the largest drivers in child healthcare outcomes, and not necessarily in mortality. So in mortality, it's not as clearly described, but in other sorts of morbidity studies, it really has played a very large role. But this is not a new topic. How many of you have actually heard of this concept before, where maternal education is super important in child health? Yeah. So this isn't a new topic. In fact, in Brazil in 1992, there was this huge study performed that actually looked at this exact topic. And so people in our own country here have been looking at this topic for a long time. This idea is not a new idea. And so it's this idea that we have to raise up the mothers within our communities, because if you raise up the mothers and you give them more autonomy and you give them more education, that everything is going to change and be better in your community. And child health is one of those things. So the studies, I encourage you guys all to go out and look at some of these studies, because they're quite fascinating. This is, as I read through this one, it was, as far as the study goes, it was okay, but it's the general concept that this isn't a new idea and that we've known about this for decades, for generations, in fact, yet here we are still with children dying and not doing as much as we can to really help to look into this problem. So if we look at a newer study, it's one thing to just know that maternal education is important, but one thing that's, I think, a little bit different and sort of that next step is actually putting investments in their children's health. So they didn't actually look at healthcare outcomes in kids, but they actually looked at more of, was the mother seeking sort of preventative services and health education for their child at really critical developmental stages. And they found that mothers that had a higher education level were investing a lot more in their child's health at really critical points in time. And so it's not, so it's sort of this trickle down effect that can persist for generations, of where the mother is now showing this behavior to their child of, oh, it's really important to be thinking about these parts of your health. And so we need to invest in it by going to a primary care physician, by having an annual checkup, by doing these different things and assessing for development that then is going to help to increase their healthcare. So I have to run through the last part very quickly about increasing access. Does it really matter? Does it change outcomes? The short answer is yes. And there are a few different ways that we can think about it. So one is increasing utilization. And so we showed that just by increasing access, by giving patients coverage to access the healthcare system, they actually go. People will go see a doctor if they have medical insurance, or if they know that they're not going to be charged some really significant large bill. And so the financial stress of going to the doctor is a large one for families. And so this was a study out of in Vietnam that actually looked at the impact of health insurance on children accessing the healthcare system, and it showed a really large increase in patients actually going in to see the doctor to get their preventative care services. On a health standpoint, so this is just one example of how it can really impact the healthcare outcomes of kids, and that's improving growth and nutrition. And so in Argentina, they did this big study, and they looked at a lot of kids that were malnourished, and they were underweight, and they had stunted growth. And they showed that just by increasing access to the healthcare system, that their growth, development, and nutrition all improved, which is a really positive impact for kids if we're thinking about children under 5 and their developmental milestones. The economic benefits have been very well described in a lot of ways. This is just one example in Thailand, where they showed that by improving universal healthcare coverage, that then they provided healthcare to these families for free. They found that these families then had higher levels of income and then consumed more products within their economy. And so if you raise the healthcare level and the health education and the access and coverage and availability of their healthcare services, that you can actually improve the economic stance of an entire country. And so it's more than just the individual impact, but now we're looking at making community, regional, local, national, potential worldwide economic impacts when we improve healthcare access. And then the biggest one that we look at, because of the first few slides, improvements in mortality. So there actually aren't a ton of great studies, but this one was done in sub-Saharan Africa, and it hints at the fact that likely there's great potential for a reduction in child death rates, but this is a really complicated problem. And another study looked at that sort of the complexity to this, because it's more than just being able to go see a doctor. It's more than just having a clinic close by. It's more than the proximity standard. It's more than abating the transportation issues. It goes back to that slide that had so many different aspects that go into the healthcare. And what they found is that the social support that the families and parents and the mothers in particular had in particular regions really reduced the mortality, in conjunction with being able to access a closer clinic or have no, their transportation barriers completely destroyed, which is great. So the main goals for the future, as I see them, are increasing maternal education. The studies are just so striking and they're very powerful that we really have to do what we can to, in a lot of these areas, to empower women to become more autonomous, to have some of their own financial stability, to elevate their education, to elevate the women in these societies. It's very important. To increase children's coverage and promoting increased access. So I didn't dive too much into coverage versus access, but really we need both. We need children to be covered from the financial side of things, but we also have to be able to provide them this sort of multidisciplinary access to care based on their transportation, the logistical side of things, but also being able to provide quality interventions. It's really important that we focus on reducing out-of-pocket costs for families. We need to improve primary care and preventative services. So many people only go to the doctor when they're sick or when there becomes a problem. But if we were sort of looking for these preventative measures and doing primary care a little bit better, then we would be able to really help with this problem on a larger scale. But we aren't putting resources into it because primary care doesn't make anyone money, or so they think. But we really have to start thinking outside the box to get this done. And so that's where it takes all of us in this room. You guys are all bright medical students. I know some of you are going to pediatrics, and that's very exciting. And so we have to start thinking creatively, thinking a little bit differently about the ways that we can really empower our communities to take charge of their healthcare and really utilize the resources at our disposal. So these are our take-home points. Child health has improved dramatically over the last 30 years, but we still have a problem, and 15,000 kids die, and there are very large disparities between countries with lower socioeconomic status, as we can see. Generally, we're improving both coverage and access has favorable outcomes in multiple domains, from the individual healthcare delivery domains to larger economic success for different countries. And then maternal education is vital to child health outcomes and must be prioritized. And lastly, access to quality healthcare is a very complex issue with many contributing factors and barriers that all need to be addressed on their own accord to help bring it all together. That's all. Thank you, guys. Tell me.
Do you have another microphone?
Yeah. No, that was great, Mikey. Very, it's a vast topic. I just have no questions, just a quick comment. We're often so sort of short-term in our thinking, but in order to improve the world, right, we need to be very long-term. This is very like anti-American, because we are such like need immediate gratification. But the whole maternal education piece, right? What that really signals is that we have to strive for gender equity in our world. We have countries that don't send their girls to school still. And so that is, destroying entire communities and the health of communities. So gender equity will lead to, improved maternal education, and then improved health of the family and health of the communities, right?
It's very important. I wish I had 4 hours to talk more about these topics, because these are the really important ones. So I had the great opportunity when I started college to take a course where I learned about different topics in social justice, and that's sort of what led me on my entire path to become a physician and to really fight for kids. And I think gender equality is something that we actually didn't talk about in that class, but has become this very strong driving force in a lot of the work that we do on a global scale.
More comments, questions? No? Yep. 1 second.
Yes. That stands for socioeconomic status.
Yeah, it's socioeconomic status, right? Okay, thank you. I didn't get that.
Yeah, so there are just big disparities between the higher socioeconomic status countries and the lower ones, which we typically have been finding in the sub-Saharan African countries.
Right. One extra question also. Regarding the training that you did on this healthcare regarding maternal and infant care to improve better health levels and everything, did you ever had any studies, or did you try to correlate this maternal status regarding like jobs and things like, were they working mothers, or were just full-time mothers and staying like housewives all the time?
I didn't look specifically into the demographics in those studies, and there are so many of them out there that to put it together, concisely put it into this presentation was a little difficult. But no, I didn't look specifically at the demographics, but really what they're looking at is maternal malnutrition, and actually just lack of prenatal resources, prenatal care and monitoring has led to a lot of these issues. If you saw one of the largest killers of children under 5 is prematurity itself. And so if we look at all of the risk factors for prematurity, and a lot being the lower, more impoverished patients, malnourished, younger age of being pregnant, a lot of these issues are things that are impacting these countries a lot. And so that's where we're trying to really build up the initiatives to work on that. If you looked at one of the sustainable, I didn't put it in red for the Sustainable Development Goal 3, but one of them is improving access to reproductive health care resources, as well as adequate levels of contraception and birth control for all people.
All right. Okay, thanks so much, Mike. Well, so now we move to another field. So we were talking about prevention, health coverage, and we'll be talking now about a very specific field. We'll be talking about Hansen's disease. And I would like to invite Dr. Jessica Foley. So Dr. Foley is a great collaborator, she has been working with us in projects here in Belo Horizonte, but also in Governador Valadares, and she'll be sharing with us a little bit about her perception on the new tools to better understand and control this important disease. So Dr. Jessica will talk about spatial and temporal variations in local transmission of Hansen's disease in Minas Gerais, Brazil. So please welcome Dr. Jessica Foley.
Okay. I think I'll put it back on. Yeah, that's fine. Yeah, it's good. I think it's good. Can you hear me? No? No. Now can you hear me? That's really close. Okay. Okay. So thanks for having me here and inviting me to speak on a topic that I'm very passionate about. I'm going to dive a little bit more into this title, since I have a lot of things to talk about, a lot of ideas and a lot of work we've done. So, but I will try to focus a little bit about Minas Gerais, because that's where we're working, and how some spatial characteristics and kind of new ways of thinking about transmission and control. Okay, so our objectives will be to understand the challenges surrounding Hansen's disease transmission, describe the spatial situation in Minas, like I said, and describe potential effects, particularly of helminth co-infections on transmission, but we'll talk a little bit about some other factors as well. I might go back and forth between leprosy and Hansen's disease. I understand in Brazil that we don't really use leprosy anymore, but Hansen's disease is a little bit of a mouthful, and we generally in the global community, we still usually refer to it as leprosy. But with my patients, I would always say Hansen's disease. So what is the disease? So this is caused by Mycobacterium leprae. It's an intracellular bacteria that produces a chronic infection. So can affect peripheral nerves, skin, eyes, mucous membranes. And some of the students out there may have, if you've been on any clinical rotations, may have seen some cases. It's the only bacterial infection to infect nerves directly. So what does that mean? You may know other infections that affect the nerves: rabies, herpes, chickenpox. Many viral infections affect nerves, but M. leprae is the only bacteria to do so. And that can lead to what we really consider as kind of the dreaded complications, being permanent nerve damage, visible deformities that will happen if not treated in a timely manner. So these are 4 of my patients that I have in the US. I don't know how well you can see it, but these are just very subtle manifestations, but you can see that there's, it can present in many different ways. Does anyone know what this is on his leg? You can see back there. You think, so this is why he came to care. So this is a burn from a radiator. So he couldn't feel any of that. So his whole leg got leaned up against a radiator and he didn't know. So that was actually a burn. So having numbness at the site of the lesions is what we call in medicine a pathognomonic sign. So not everyone will have that, but if you do, it's Hansen's disease. These are also the signs. So you can see all 4 of these patients had absolutely no sequelae, so they did not get any permanent nerve damage because they all came to me in a general, a timely manner. But unfortunately, this is the reality in many parts of the world, with access to care being a huge issue, as well as many other barriers, which I'll get to. So some of these are what we call fingertip absorption. So the bone kind of gets eaten away. That's here and here. You can have permanent eye damage and blindness, and also just kind of disfiguring lesions that can obviously be very stigmatizing. I just put this up here just so we can kind of think about this as we go further into the risk factors for transmission. But these are what we call the Ridley-Joplin classification. So the patient at the far end a couple slides ago had tuberculoid, and the patient on the right end had lepromatous. So this is really the kind of the spectrum of infection. And if you see here, it's really about cell-mediated immunity. So which lesions you get kind of depend on how good your immune system is at fighting the particular bacteria. So lepromatous has poor M. leprae cell-mediated immunity. Doesn't mean that you're going to get other infections, but you may present with lepromatous. So where are we right now in terms of infections? There are about 200 new cases every year. 9% of these cases are in children. So that's an important thing to think about, because if children aren't getting infected, then it means that there's still transmission in the community enough to expose kids who haven't been around that long. We really haven't seen any improvement for over 10 years. This number really we had a huge drop in the 80s. Anyone know what happened in the 80s? No, just for Hansen's disease. Treatment, thank you. So we perfected, or at least as much as we could to this day and age, mass drug administration. Dapsone came into the 40s. So we did have Dapsone, but it was multi-drug therapy that really brought the numbers down, as well as a push from WHO. Some people, though, think that these numbers are maybe 4-fold underestimated. So we're talking a lot of hidden infections in many areas. This is kind of just looking at, 2016, the most recent map they have up on WHO. So this is not new case detection rate, it's just new cases. So India and Brazil are the top 2 of number of new cases. India is really, I think, has over 2/3 of the cases in the world. But if you look at incidence, so how many new cases per year, per 100,000 per year, Brazil actually has a higher incidence. Just as a comparison, TB is about 42 per 100K, and Brazil has an average of 15.3, but that's very much an average, and we'll see about that when we look at spatial distribution. The Marshall Islands tends to be the highest, has the highest incidence. It's a very small set of islands, but they have what's called hyperendemic Hansen's disease. And so what does the WHO have to say? So one thing they said in 2000 probably had a negative effect on control. So they said that after that great campaign, we have now eliminated Hansen's as a public health threat. So that brought it down to less than 1 case per 10,000 prevalence. However, the problem was that was overall numbers and did not address pockets of higher rates. So this happened and resources were removed from programs. So if you say it's not a problem, why should I do anything about it? So that was the attitude of a lot of ministries of health around the world. Now, kind of where the WHO is realizing that they really need to get back up with their global strategy. So these are some of the goals and targets, which doesn't look so clear here, but really just kind of looking to have some targets about bringing number of children diagnosed down to 0 with visible deformities in 2020, or I think that's 2020, might be 2030. And then bringing down the actual number of visible deformities overall to less than 1 per million, and then number of countries with that do not have laws discriminating against those with leprosy, and that's target is 0. Okay, so I've highlighted a couple of reasons why there may be some barriers to control, with probably stigma being very high up there. But in terms of the bacteria, the problem is you cannot grow it in a petri dish. You cannot grow it in vitro. So that really hampers how you can study an infection if you can't kind of look for it in different places and kind of and figure out how it's being transmitted. It also really impacts how we diagnose it. So it's very difficult to diagnose it, and physicians are not recognizing anymore. So a lot of places in the US, I would say most people would have no idea, and I have seen delayed diagnosis and misdiagnosis lead to irreversible damage. Underreporting, so just the cases aren't being reported, or they're just being missed. We don't have a good diagnostics tool, and we kind of mentioned that there's complacence and low investment in programs. Also, we kind of looked at some big numbers, but one of the things I really wanted to emphasize today in the lecture is that it's really not about the big numbers. So remember, this is taken right from the map. So it's got a big shaded, it's pretty well dark over here, but do you think the cases are the same here as here? No. You ask people from Rio and they have no idea what Hansen's disease is, or if that it's a problem at all. So here is kind of a classic, you see it in a lot of papers, but the classic 10 most probable clusters of Hansen's. So a lot of the cases are kind of concentrated in the northern states, and in Minas, they're concentrated more on the east to northeast. But even in Minas, you can see we have differences. This is 2017 cases. So you can see some concentrations of where there's a highest burden over here and over here. But this gets into what we're going to talk about in terms of spatial analysis and geographic information systems. Also, actual case numbers don't even tell the whole story. So first, you've got averages that don't really point out the high burden areas, but you also have numbers that you might not be able to trust. So here we have, these are courtesy of the Secretary of Health here in Minas Gerais. These are number of new leprosy cases per year since 2002. So you can see there was a really nice drop off and overall improvement in cases. although there has been, again, a leveling off in the past 5-6 years. But if you look over here, this is the proportion of grade 2 disability diagnosed in new cases by year in MINUS. So grade 2 disability means that what? That you haven't been diagnosed. If you're presenting with really bad disability at the time of diagnosis, you've had the infection for a long time and you haven't been able to get to care. So sometimes if you don't know if these numbers are telling you the whole story, you can look for alternative epidemiologic markers. And for Hansen's, grade 2 disability is one of those alternatives. So you can see that actually the percentage has slightly gone up over the last 15 years. So if we really were making progress in finding at this much progress, we should be seeing these numbers go down. And these are just some other kind of maps looking at where some of the cases are. This is I have an Emory student working on a spatial analysis and climate change. This is just picking 2 kind of years within that 15 years. So you can see number of new cases as well as incidents. And the darkest being what we call, or the second darkest being what we call hyperendemic, and then the darkest is really, really hyperendemic. So you can see some of these dark areas around here. Of course, when you have small municipalities, this can be a little bit, one case in a small municipality might make it look like a bigger problem than it is. So we had to take that into account, and we can do that with spatial statistics. But just to see, don't see a really big difference over these 5 years. And then here's another way to look at it, kind of which municipalities have at least one case each year. So over the 5 years that she was looking at, you can see that the municipalities with cases have had them most years of that 5 years. So you would like to see, these go down as you're making progress. So, and then this is grade 2 disability over time, just number of grade 2 disability at diagnosis. And this allows you to kind of maybe target different areas that maybe having a harder problems with access. And you can see again, kind of at the periphery of the state, at least in 2017, still seems to have some issues with that. Okay, so that just is giving you kind of a little bit more about the spatial situation here in MINUS. But I really wanted to talk about kind of, well, what's going on? What are some of these transmission factors? So first, to do that, you have to know a little bit about transmission. So our traditional thinking is that the cases are transmitted person to person. So probably from the most heavy infected individuals, which would be lepromatous or multibacillary, probably respiratory tract and mucous membranes, kind of inhalation, just like the flu in some sense. But there has been some report about skin trauma and accidental inoculation. So another thing is that the incubation period is very long, so it's very difficult to study transmission. So incubation period is about 1 to 20 years with an average of 2 to 5. But is this the whole story? So in the US, there is a very different way that people may get MLEP, right? And we've realized that that's maybe the case in Brazil as well. So let's talk about where the infection is. So reservoirs of infection. So meaning where are these? Where are people getting these from? So people. So we know that. Oops. Yeah. Oh, sorry. More people. So armadillos. Had anyone heard of this? Yeah. Do you guys see armadillos in MINUS? I got some yes, no. I've heard that that in some communities, yeah. It's the only really known animal reservoir. And then the big question, kind of connected to armadillos, is maybe soil, water, and contaminated environment. So there. And some of this case, this isn't a talk about environmental reservoirs, but there have been some, these are all different studies that have shown given support to M-leprabine in reservoirs of water, of soil, and amoeba, so free-living amoeba. And that's thought to be the connection with armadillos. So who gets infected? Well, fortunately, it's accepted that only about 5% of the world's population is susceptible. So most of us are not susceptible. And that's probably associated with innate and adaptive immunity, possibly with genes. But, you know, what I'm most interested in are other host factors that might play a role in someone's host susceptibility or the way that you present with the infection. So how do people present with infection? So typically, you know, 95% will be exposed or contact, and this is repeated contact. This isn't just walking by someone. This is being close or in a community where there may be a lot of encounters with an infected person. Then you have what's called indeterminate, and this is the spectrum of disease. So as the cellular immunity towards the infection goes down, the bacteria goes up. So that's the general thinking. Of course, it's a lot more complicated than that, but that does give us some ideas for how to model different transmissions. So for any infection, you need a reservoir and you need a host that's susceptible. So this is thought to possibly be, you know, you have these reservoirs, you have the possible increased risk of multibacillary infection, which will sustain the community reservoir. Man, this is, I was laughing at everyone else that was having trouble, and now I am. And so these are some ideas of what, you know, where people might have reasons for a host susceptibility. So helminth infections affect, so this is like schistosomiasis or other helminth infections. Vitamin D and vitamin A deficiencies have different effects on susceptibility to infection, especially vitamin A. So this is really, and also just kind of nutrition in and of itself can make someone more susceptible or not. The literature doesn't tell us much. There are some studies that kind of support our approach. Two studies have looked at a higher risk of leprosy, in particular multibacillary and helminth co-infected patients. In both of these studies, these were both soil transmitted helminth, so not schisto. And also a lot of studies from Mycobacterium tuberculosis also support the same shift in the immunity away from what we call a Th1 or cell-mediated. Oh, I knew that. This looked totally fine on the computer. So I'm going to just skip it. Okay. Even that computer looked totally fine. It did it. So what are we doing to address some of these? So here, besides looking at the spatial and temporal associations, we're working with Lucia to look at hyperendemic areas. And these are both for leprosy as well as schistosomiasis, and multiple studies within this kind of looking at transmission, nutrition, immunology, and spatial factors. And then I also work in Ethiopia where we're doing a similar thing with a little bit more focus on some water, sanitation, hygiene factors. So since most of our work to date has been with schistosomiasis, I just wanted to give you a little bit of primer. If you don't know, that Minas Gerais is one of the states that still has schistosomiasis, mostly concentrated and the same areas where we saw that cluster of Hansen's disease. And this is the life cycle. So the exposure is from fresh water or kind of going into fresh water and getting infected. I'm going to skip that. So the first thing we did a few years ago was actually just did a very small spatial study on the two infections. And over a 7-year period, we found that Hansen's disease and schistosomiasis tended to travel together in Vespasiano. There were, low numbers of cases, which was a limiting factor. But even when we controlled for purchasing power or socioeconomic status of these different neighborhoods, we still saw a pretty high correlation between the two infections. And this seemed to go up with the Hansen's disease incidence seemed to go up with the number of cases of schisto. We brought this out to a bigger area. So this is Governor Valladares region. And we looked at leprosy annual incidence here and schistosomiasis. And all these dark areas are what we call hyperendemic for numbers. And we didn't find a strong, as strong a relationship, but we did see that multibacillary Hansen's disease seemed to be more associated with schistosomiasis. We did see an expected association with increased population density. So that's one of the big factors. The more people you have around, the more likelihood of spread. We also saw, unfortunately, a high percentage of children, 0 to 15, or under, is actually under 15, about 8.6%. And this is much higher than the Brazil average and the world average. So those are kind of the big pictures. And kind of going to the host, we took some of this literature and decided to investigate ourselves. So we looked at cases, new diagnosis of Hansen's, looked at 2 groups of controls, and then and how schistosomiasis in particular, or any other helminth infections, were associated. So again, we had a, and this was not, we did not try to get children. They were just, this just was who presented or how during our time enrolling. So there, but we did have about 12.5% were children. Only 1.7% grade 2 disability, which is pretty good. And we'll get there, why I think that's the case. And about 14.6% active schistosomiasis in the cases, and about 8.3 overall. I guess I don't have any animations here. So we also did serology for schistosomiasis and found 35% of our study sample had an infection, either recent or in the past. Quite a bit were vitamin D deficient, about 14%. We did not see any vitamin A deficiency, a little bit of iron deficiency, but quite a bit of anemia. So that was interesting. This was before they started treatment. So we did see about a third. It didn't matter. Anemia was not, it was not associated, at least with controls and cases. So, and then looking at kind of logistic regression, we did find a strong association with active schistosomiasis and leprosy cases, about 5 adjusted odds ratio of 5, without really any other, maybe slightly age, but we controlled for socioeconomic status, vitamin D deficiency, anemia, and sex. When we did this with serology, we did not find the association, so it seemed to be more of an active infection. When we looked in this small community, so this we did a highly endemic area, even more so concentrated. We found 44% tested positive for schistosomiasis. This was important. We found 42 cases of Hansen's disease just within our study. So we found new cases by doing a public health campaign of kind of contact tracing of known cases. And to be honest, what we did, was obviously, sobering. We didn't want to find that many, but one, it does show that there are cases out there that are not being diagnosed and reported. But it also showed the benefit of aggressive surveillance. Do you remember how many cases of grade 2 disability we diagnosed? Just one. So that's a lot lower than the MENAS average of new cases with grade 2 disability. This had a stronger association with schistosomiasis as compared to controls. And this area is it does have a lot of schistosomiasis in that area. This is just a quick thing to look at the immunologic supports. So we did find higher threshold or higher kind of median IL-10, which is associated with Th2 immunity in the schistosomiasis co-infected cases. I'll skip over that. So to kind of summarize, we talked, I think I remember someone else talking about holistic approaches during our time here, but we really need to address the reservoir as well as addressing the hosts. So contact tracing, treatment of cases, post-exposure prophylaxis is something that a lot of groups are doing, and a lot of studies on new ways to treat contacts with 1 or 2 doses, improve surveillance, and then more research on some of these water sanitation and hygiene factors and the armadillo and maybe association. So there has been a big study in northern Brazil and Pará that have shown a strong a significant support looking at the genomes for armadillo-associated infections in Brazil. So that's a big area. And then addressing the host, so looking more at the immunology, which we'll be getting into more with our sample, and more research on other things that kind of affect the Th2 response. I mean, obviously, helminth infections is not the reason for most of this, but it does travel. Many parts of the world have both infections. Nutritional deficiencies, looking more at that, since our study in Ethiopia showed a very strong association with low BMI and underweight and leprosy as compared to controls, and targeted programs addressing these other conditions. So leprosy transmission is complicated. We think that co-infections may have, especially helminth co-infections, may have important effects on host and predisposition to leprosy. And it may be the reason why some people have a latent infection their whole life, and some people show active leprosy, just like TB. The only 5 to 10% of people with latent TB will get TB. I believe that that's a similar thing with Hansen's. So we had to move beyond contact tracing and think outside the box. And these are just a couple of our ongoing studies looking at metabolomics or metabolic signatures and biomarkers of infection, and a serologic multiplex that can identify possible latent infection and look at transmission factors over time. So I will skip over that. So, obrigada. This is just showing some of this is Emory students and myself at the Colonial Santa Isabel, Limera, where we did a lot of our work, presenting, having Lucia translate for me in Valadares. And this is also showing other partnerships. Claudio Salgado is the president of the National Hansen's, the Brazilian National Hansen's program or society. And thank you, obviously, to Lucia, to Jose, to Sandra Leon, and other, Thelma, who's here, and other people that have made these projects possible. These are big group doing field work in Limera. These are Emory. I couldn't even have any room to put all the students that have worked on the programs. Many of you guys have, so both on FASE and Emory. So I'm very thankful for that. Here's a few students presenting. Here we were presenting at the Congress, National Congress. So my next lecture will be a lot shorter. So if I went over. Okay. Any questions, I guess?
Hi, Jessica. It's a pleasure to see you again. And my question is, in our study, a pilot study in Eduardo de Menezes, and in your study in Valadares with Dr. Lúcia, we didn't find an association between multibacillary form and infection and Helminth's disease, especially schisto. Do you think that the studies by about metabolomic can answer this question? Or do you think that if we increase our sample, we can answer this question?
All right. I mean, with our first study, we didn't have a control group, so that was partly the issue, but we did have quite a bit of serologic positivity. Our group, we found the association with leprosy in general. So my thinking, I've shifted a little bit of my thoughts that it may not be all about causing multibacillary infection. It might be this just shifting your immune system from controlling the infection and staying latent to having symptoms. And then maybe there is a predilection for multibacillary that we just didn't find, but other studies have. We had a lot of demorpho or borderline with low bacillary index. So I think it's a sample size number thing, but even without the multibacillary, I think there is still this cell-mediated immunity driver of co-infections. So.
Okay, thank you.
Yeah.
Hello. I was just wondering if the immunosuppressed population is generally more susceptible to leprosy than the general population.
No, it's not, which is hard for us to understand that. But no, there's been most of the studies have been with HIV, and there's been really no association. The only, I have my suspicion that. I mean, it probably depends what the immune suppression is. So maybe we just haven't looked specifically at the spectrum of Hansen's and a co-infection like HIV. We do know that if someone gets on treatment for HIV, they're likely to have what's called an iris reaction or immune reconstitution, and so they will have a leprosy reaction. But there hasn't been, it's not like a classic opportunistic infection.
Okay. All right. Thanks so much. Okay, let's move on. So I would like to change completely again the subject, and we'll be talking about arbovirus now. So we have a special guest tonight. So Dr. Betânia Drummond is a professor at Federal University of Minas Gerais in virology laboratory. And I want to invite Dr. Betânia to talk a little bit about the yellow fever situation in Minas Gerais. So please welcome Dr. Betânia.
Good night to everyone. Thank you, José, for the words. I'd like to thank you, the organization, for the invitation to be here and to participate of this moment of celebration. And I'm going to talk a bit about the persistence of yellow fever in Brazil. As you may know, yellow fever is an arbovirus that is transmitted to human beings and non-human primates through the bites of infected mosquitoes. And despite the fact that we have a vaccine to protect against yellow fever, thousands of cases took place each year in endemic areas in South America and Africa countries. And yellow fever usually occurs in remote areas where patients have little or no access to a good medical care, advanced medical care. And because of that, we know very little. There is too much to learn about yellow fever. And although yellow fever is a known disease, recent and huge outbreaks in Brazil and in different countries in Africa reinforce that the yellow fever is still an important health public in the world. And the recent outbreaks give us an excellent opportunity to study and learn a bit more about yellow fever. We know a bit on yellow fever pathogenesis. After the bite of the mosquito, the virus go to lymph nodes where it replicates, and then the virus disseminates to different organs. And it's believed that the viral replication plus an unbalanced pro and anti-pro-inflammatory cytokine response is the responsible for the tissue lesions that are observed during disease. As far as we know, yellow fever is considered an acute disease that lasts from 7 to 40 days, and it has different phases. The first one is the infection phase that lasts from 3 to 6 days. The disease starts with an abrupt onset with high fever and other symptoms. And during this phase, the patient has viremia, and he can transmit the virus to mosquitoes. And here we can observe increased levels of serum transaminases. After this period, in many cases, the symptoms disappear, and given the immune response, most part of the patients recover from the disease. But in some cases, after what we call the remission period, that may last from few hours up to 2 days, some patients have a worsening of the clinical status. And they enter into the intoxication phase that may last from 3 to 8 days. And these represent 15 to 25% of total cases. Here we can observe a worsening of the symptoms, and serum transaminases reflect the severity of the disease and are considered prognosis markers. And 20 to 50% of the patients die, and the one who recovers enters the convalescence phase, but we know almost nothing about this phase. Here in Brazil, we do not have the urban cycle since 1942. When the urban cycle occurred here, as Aegypti was the vector and human beings were the host, the vertebrate hosts in urban cities, urban centers. But we still have the sylvatic cycle, and the main vectors are hemagogos and sabetes, and non-human primates that live in the tree canopies as these vectors are the vertebrate hosts. And once in a while, human beings enters the forest and they can get infected. Yellow fever is endemic in the Amazon basin in this region. And here, the virus causes episodics and eventually some cases, but here we have a high vaccination coverage. But eventually, the virus can go out of this region, and it can cause outbreaks, usually small and sporadic outbreaks outside the Amazon basin. mostly during the epidemic season that goes through from December up to May, when we have more rain and more mosquitoes to transmit the virus. And here we can see the historical series of yellow fever cases from 1980 to 2015, when we had in Brazil 1,500 cases. But in last years, this picture changed dramatically, when we have a huge, an amazing increase in the number of yellow fever cases. Only from 2016 to 18, we had more than 2,000 cases with more than 700 deaths, mostly concentrated in Southeast region and mostly in Minas Gerais state. That was the epicenter of the outbreak. And Minas Gerais state had 46% of cases and 45% of all deaths reported during this time. So when the outbreaks started, we started an investigation of yellow fever in monkeys, since several non-human primates were dying and being collected inside urban centers. And we investigated non-human primates carcasses from different places of the state, collected in rural, peri-urban, and rural areas in 2017 and 18. Most of them from 2017 were from this region, and then in the following year from this region. And from 733 carcasses that we analyzed, 245 were positive for yellow fever in PCR reactions, with an average positivity of 33% of the monkeys. We still need to analyze the samples using serological tests, since some of the samples may not have the virus or the RNA preserved. And we detect the virus in different genera of non-human primates. And an interesting fact that we observed, that Calicebus, that is considered less susceptible to yellow fever infection than Calitrix, had the same positivity when compared to Aloata, that is highly susceptible to yellow fever infection. And maybe this may reflect the sensibility of this genera to yellow fever infection. When we analyze data regarding the environment, most of the positive animals were from rural areas, higher than urban, and then peri-urban areas also had more infected animals than urban areas. But we found a high positivity rate in urban areas in different places in Minas Gerais. And this is consistent, this gradient is consistent with the yellow fever circulation and dispersion from the rural to urban areas, consistent with the sylvatic cycle of yellow fever, that is influenced by the distribution and susceptibility of vector and host, and also distribution and vectorial competence of the mosquitoes. But we detected yellow fever in different urban areas. And here I want to illustrate. Here is our metropolitan region of Belo Horizonte. Here is the place of our campus at Pampulha. And here we can see different places where we received monkeys that were positive for yellow fever in 2017 and 18. The virus was here, very close to us. And despite the fact that we had several monkeys, infected monkeys here, we did not have any urban case of any human case related to urban transmission, fortunately. But it's important to know that the marmosets are very common in urban areas in Brazil. We can see them anywhere. If you start eating something, they will appear for sure. You know, if you're eating something in the streets, they're going to appear. They're very common in urban areas in Brazil, and they are very common inside these forest pockets that are very common in our urban areas here in Brazil. And the presence of the virus inside urban areas is a risk for reurbanization of yellow fever. And we need to pay attention and to investigate it in a better way. Maybe we didn't have urban transmission due a lot of factors that may include in some cities like Belo Horizonte, we have high vaccination cover to yellow fever, some ecological barriers since the monkeys are in the tree canopy and the mosquitoes that are there are different, and Aedes aegypti is a very anthropophilic mosquito. And the vectorial competence is also another issue that may be influencing this. But we're starting different studies to investigate, especially a bit of this. And when we look at for the period that yellow fever was detected in Minas Gerais in monkeys, we detect the virus in the whole year of 2017. We didn't find infected monkeys here, but data from the Secretary of Health detected positive monkeys here. And we observed this pattern of a positivity during this year and in the beginning of this year. And we asked ourselves at that time, is the same yellow fever lineage causing the epidemics and episodics from 2017 to 2018? So we investigated some samples, positive samples from human and non-human primates. We amplified part of the yellow fever genome, and we get the sequences and performed some evolutionary analysis. And here we can see this phylogenetic tree. Here are strains from Africa, and here are strains from Brazil, and here strains from Brazil. And we can see that the yellow fever strains from Southeast Brazil, from São Paulo, Minas Gerais, and Espírito Santo, clustered within the South American clade. That is the genotype that circulates here in Brazil. And all these strains had one common ancestor, a single origin, dated at 2015. So this indicates that the virus could be here before the outbreaks started at the end of 2016. And when we look at, we didn't have strains from these years to sequence and analyze here. But when you look to epidemiological bulletins, we observed that here in Goiás state, a neighbor state of Minas Gerais state, yellow fever cases were reported in animals and in persons in 2014 and 2015. And usually when we have yellow fever outbreaks in São Paulo, in Minas Gerais, we have yellow fever cases here previously to cases in Southeast region. So this might indicate that the virus could come from this region, from Amazon basin, passing through this region, reaching Minas Gerais state. So this data showed to us the persistence of yellow fever outside the Amazon basin, causing episodics and outbreaks in urban and rural areas in Southeast Brazil, at least from 2016 to 2018. And the Southeast region of Brazil has, this persistence indicate that Southeast region of Brazil has climate and ecological settings allowing viral persistence here in our region. And we need a lot of studies to better understand these ecological and evolutionary and biological properties of this new lineage that was isolated in these recent outbreaks. Regarding the humans, during the patients, during the outbreaks, we started at the beginning of 2017 with a great team, the guys from Eduardo de Menezes Hospital, Fiocruz Minas, Secretaria de Saúde, my university, and Fundação Ezequiel Dias. And we are trying to answer different questions related to different aspects of yellow fever. I'm not a medical doctor, but I talk a bit about a disease for you, a kind of new syndrome that we are observing. During yellow fever epidemics, many cases took place in Minas Gerais, and many of those cases where those patients were admitted at Eduardo de Menezes Hospital in these years. And patients were admitted in different phases of yellow fever based on the symptoms, the beginning of the symptoms, and the symptoms they report in clinical signs. And the hospitalization period dured from 1 to 67 days, when we see the 2 years, with a median of 10 to 12 days. For hospital discharge, the patients had to present more than 7 days from the onset of the symptoms, absence of fever for more than 48 hours, no cardiac or hemorrhagic manifestation. The patient had to have an improvement in clinical status and renal liver functions, and transaminases decreasing and lower than 1,000 units per liter. Okay. And then the team from the hospital advised the patients to come back for the follow-up after 15, 30, and 40 days of the medical discharge. And when the patients, here you can see the AST and ALT levels during the hospitalization, and here after the hospitalization when they started to come back for the follow-up. And the transaminases were decreasing until a period, after a while. In some patients, the doctor started to see the increase in ALT and SAT levels. In some of these cases, the patients were asymptomatic, but in some cases, the patients were symptomatic. In some cases, they presented jaundice, abdominal discomfort, asthenia, among other symptoms. And in some cases, patients needed to be admitted at the hospital again due to the clinical status. The guys, we all looked for similar clinical picture in the scientific literature, and we found nothing. So we named this condition as a late hepatitis syndrome after yellow fever. And based on the patients of 2017, it started from 30 to 6 days after the onset of the symptoms, when you observed an elevation of transaminases, and after a while, these levels decrease. And this elevation, the transaminases were higher than 500 units per liter, or at least twice the lower level during the convalescence phase. When we looked for the levels of these transaminases, we saw no difference during the hospitalization when compared patients who had late hepatitis with patients who didn't have late hepatitis. But during the convalescence phase, during the period that we start to see this clinical picture, we observed a difference with increased levels of these transaminases in patients who had late hepatitis. And we looked for the possible causes of this picture. And we tested samples for yellow fever. We did not find yellow fever in serum samples. And we also test the samples for other agents, as dengue, Zika, chikungunya, several hepatitis, autoimmune hepatitis, and the results were negative. But we still decided to look for yellow fever, since we know that persons vaccinated with yellow fever 17DD may have the virus up for 2 months. So we take samples from these patients and look for genome and antigens. And here we analyze eight patients from 2017, and we were able to detect the yellow fever genome in urine samples from 66 to 68 days after the onset of the symptoms. And these results were confirmed by nucleotide sequencing. And here we have a very interesting case. This patient had yellow fever. He was admitted at the hospital, and here he had hospital discharge. He has no longer jaundice, but after a while, approximately 2 months before the onset of yellow fever, he had jaundice again and increased levels of transaminases up to four months when the levels were normal again. And we had the opportunity to analyze a liver biopsy collected here 3 months after the onset of the disease. And we detect yellow fever genome in the biopsy. And, And here in this phylogenetic analysis, we can see the virus from obtaining in the urine of those two patients, patient 1, patient 2. And here is the sequence from the liver biopsy from this patient 3, confirming that we had detected yellow fever and wild type yellow fever, since the vaccine strains are located in a different part of this tree. And Dr. Marcelo Pascoal from Fiocruz performed some histopathological analysis and observed hydrotropic degeneration without necrosis, which is compatible with the convalescence phase. And when he performed immunohistochemistry analysis, he detected yellow fever antigens in the zones 2 and 3 of the SNE, which is consistent with the expected location of yellow fever replication during the acute infection. We looked for the scientific literature for similar reports, and the only one we found is this one for 1972, when Francis and colleagues, during histopathological analysis of patients after yellow fevers, detected continuous liver cell damage up to 2 months, and they observed that as the disease progresses towards convalescence and high titers of antibodies, the histological features begin to resemble those of a non-specific hepatitis. So until here we observed a late hepatitis-like syndrome after yellow fever during the convalescence phase of yellow fever. This was observed in 12% of patients admitted at the hospital at 2017, and 30% of patients admitted at the hospital at 2018. Increased levels of transaminases were observed up to 4 months in some patients. And we observed another kind of persistence of yellow fever. Now, the genome and viral antigens were observed up to 2 to 3 months after the onset of the symptoms during late hepatitis syndrome after yellow fever. And we have a lot of work ahead of us, and we expect to answer a lot of different questions that we have until now. I really like to thank you all for your attention, all of your collaborators, the new ones, my team, my students, and the financial support. Thank you.
Thanks, Betania. We have time for one question, one comment. So, comment? Oh, just one. So,
that was an amazing talk. Can you talk a little bit about risk factors for the outbreaks in terms of geography and maybe socioeconomic status? And was there any difference between the 2 years in these risk factors?
We we observed the same pattern. Most of the patients were men, rural workers, exposed to the environment where the virus is. And in the first year, the virus was in the northeast part of the state, and then it came down. In the first part, the vaccination coverage was lower. It was an area that was not a recommend. It's an area of vaccination recommendation, but the vaccination was very low. Maybe this was the most important risk factor to this start of the outbreak. And we have information that monkeys were dying in the northeast part of Minas Gerais state 6 months before the outbreak begins at the end of 2016. But the results of the laboratory results came only 6 months later when the outbreaks exploded.
Sorry, I have 2 very quick questions. So one is, were any of the patients that got sick with yellow fever, did any of them have a history of prior yellow fever vaccination? And then the second question I have is, so obviously, Hospital Jimenez is they didn't take care of every single yellow fever patient, and so have you guys connected with any of the other healthcare providers? And did those healthcare providers also see this sort of like rise in transaminases in their patients as well, or was that really only what we saw here at the hospital?
The guys from the hospital had some patients that had been vaccinated and they got yellow fever. At least 6 to 8 patients, something like that. We have one patient that had 2 shots of the vaccine, and even though he was infected. But most of them were vaccinated in their childhood, and only one shot. And this late hepatitis was observed also in São Paulo last year, some cases there. I don't know the percentage of cases, but it was also reported there.
Thanks so much, Betania. All right, so let's move on, and we will have now our last talk. So we have Dr. Jessica Farley will be speaking about ethics in public health. So thanks, and help me and join Dr. Jessica Farley for the last talk for our symposium.
Well, so I was tasked with a large topic. So I just picked one aspect. And since the title had both mentorship and ethics, I chose one aspect and where these kind of overlap. So it's not going to be an extensive ethical discussion here at all. So we're going to discuss mentorship across continents because I think this is a big theme of our whole week and kind of looking at our collaborations. I'll introduce some concepts of global health research ethics in particular, and identify some examples of best practices for global partnerships. So hopefully this will be a nice way to bring in some of the different themes that have been going through the top topics this week. So this is kind of where I thought that this looks. So we have some research mentorship, and we'll get to some definitions of that, and global health ethics. And here are kind of where we see the overlap and effective and fair partnerships in global health research. And that's what I want to emphasize and discuss. Or another way you could look at it is how to bridge divides, whether this is distance or different specialties or different cultures, or possibly, other differences. These are, if you can't tell, they are related, and they do support different teams. So looking at how to bridge these divides. You should have seen me walking through Bello with these kids in 2 different shirts, and the stares and looks I got when they came with me. But they insisted. He is a Cruzeiro fan, and she is a Atlético. So let's start with mentorship. So what is mentorship? I found this nice definition actually by a colleague at Emory in a paper that she authored with others. A process whereby an experienced, highly regarded, empathetic person, the mentor, guides another, usually younger, but that's not always the case, individual, the mentee, in the development and re-examination of their own ideas, learning, and personal and professional development. So I thought this was a really nice way to capture some of the qualities of good mentorship, kind of with those empathetic. So we kind of that related to the compassion we talked about the other day, and this kind of development and re-examination of personal and professional development. So what are some considerations for these kind of cross-national mentorship? And again, Dr. Como was published a paper on their work in Ethiopia, an Emory program with a partner university in Addis Ababa, and kind of what some of their strategies to improve and foster mentorship training programs. So there is definite evidence that mentoring programs increase the quality of research conducted in global health settings. It builds capacity, so not only institutional, but also someone's personal capacity to advance their career. However, there are challenges. There could be some infrastructure differences and issues across institutions, time constraints, oftentimes, especially in lower income settings where we learned about the shortage of physicians. Oftentimes, physicians are wearing many hats, and they have a lot of clinical duties, they have research, and so mentorship might be far down the list. And then you can have communication challenges if the mentor-mentee are from 2 different countries, or even sometimes speak a different research language. It doesn't have to be different countries. It could be a clinical person and a basic science researcher that have come with different cultures. Also, there may be unclear communication goals and kind of a vague understanding of the role of mentorship. And different cultural backgrounds, as I mentioned, may also affect communication. So with that, I also kind of wanted to bring in where does kind of ethical considerations happen with this mentorship and this cross-national. Unfortunately, historically, global health research has been quite lopsided. So lopsided means just unbalanced when it comes to research. So the image of tropical medicine that's often seen in the US is the old white guy going to discover malaria, going to Africa, discover malaria meds, and then take treatment or some kind of research and taking it back, and not kind of crediting or involving the local researchers there. So that seemed to be kind of the case in a lot of these situations where someone from a high income country or area, doesn't have to be, it could be someone from Rio going to a rural area in or a smaller place in Brazil. This was often defined by what's called parachute research, as someone kind of swoops in, does their research and gets out and doesn't leave anything sustainable. And they were often inequitable situations, unsustainable and unethical. So there have been significant efforts like these kind of mentorship training programs to kind of reverse the colonial mentality. Ensuring that there's mentorship from all angles is really important. and recognizing that there could be different approaches to mentorship and scholarship depending on where you are. So, oops, I'm going the wrong way. So what are some recommendations for effective mentorship, kind of taking those into account? So we know that if you're thinking of 2 different countries, that mentor training is important. So the actual training of the mentor, not just the mentee. Establishing expectations between mentors and mentees. And this was adapted by Dr. Como's paper. Ensure sufficient interaction between the mentor and mentee. So how much is sufficient may differ with the context. Understand different styles and cultural differences. And really identify mentors in both countries for students from both countries. So it doesn't mean that you know, the US researcher has to only mentor the ones from their country. You want to kind of have this cross pollination, as you might think of. So that's kind of how I want to address the mentorship, and kind of brought some ethical considerations and kind of recommendations for mentorship. Very touched on the surface. There's a lot more reading, especially from Dr. Como's work and others. So what about just kind of touching on a little bit about some more of ethics and research ethics? So this is kind of moving beyond just mentorship, but looking at some other ways that global health ethics kind of might affect some of the work that we do with some of the students and projects. So I highlighted these are the global health concentration competencies for the MPH degree in the US. So a couple of days ago, Juan mentioned some other competency, and he may have even had this one slide up here. But I highlighted where I thought ethics fit in. So definitely this one, apply ethical approaches in global health research and practice. So this is what students should come out knowing. Propose sustainable and evidence-based multi-sectoral interventions considering the social determinants of health. I think some of the social justice components of ethics fits into this. And then display critical self-reflection, cultural humility, and ongoing learning. So really this fits into a lot of the what we talked about with mentorship, but also just the cultural humility, meaning being self-aware of where you're coming from and where the other group is coming from. So, you know, just in general, you know, some general principles are universal, but it is important to understand that some best practices may differ country to country, and that's a challenge with cross-national partnerships and ethical approval. But I think some of these general principles are universal. You know, do no harm. You have respect for the individual. Beneficence is not only do no harm, but do good for the person, the people you're working with. You know, focus on vulnerable populations. And informed consent. Where I've seen maybe some differences is some of the way you know, in the US we have very focused on HIPAA and that's another way of saying confidentiality, patient confidentiality. I've seen some kind of differences in my work, and also this more of this individual versus community. I don't try to, but how I could explain this better, but just that in the US we're very individual. You know, we don't always, you know, we're very concerned about our rights as an individual, and I think that is not always the case in other communities where the community kind of rights kind of may be a bigger force than the individual. But just some things to think about, and again, Dr. Leon talked about this, but you really need to remember your power. And when you're working, especially working with disadvantaged communities, I get worried that some people may agree to be in a study, or, you know, or say even have their pictures taken because because of this dynamic. They see a researcher coming in that has an education, that probably has more money, that is saying, I want you to do this. And they might feel the pressure, even if we try to make it seem non-coercive. They might find a pressure to agree or to do things in the study that or just, do something that you're asking that they might not otherwise. So it's really important to remember this power and dynamic and try to overcome that. Again, ensure confidentiality and understand the cultural context and practice cultural humility. So kind of in summary, coming back around to global health partnerships in a way to think about this week and what we're doing. These are all things that I hope that we, all can practice, and I think we all do well, but obviously respect is huge. We need to listen to our partners. You have to understand your own motivations and those of others. Share information. Again, cross-cultural may not be across countries. It might be a different way of approaching research, exchange of practices, ideas, identify mentoring needs, establish those connections, look for the bidirectional mentor-mentee relationship, not unidirectional, and then ensure equal and fair representation. So this can be authorship, presentations. I noticed that there was one paper that Mikey put up there from Vietnam, and not one single author was from Vietnam. So those are things that we really need to remember. Be open-minded to different viewpoints and inspire the next generation. And maybe, maybe you'll have the third who liked both of them. You can see her trying out different things that when she came to visit Bello. She's number 3. And inspire the next generation. These are students, Emory students and students from Valadares. And this is my little one at Lucia's house who also gets to have early introduction into research and global partnerships. So, and then lastly, concluding, you don't have to look far for models of successful partnerships. And here's examples of them all here. This is from our other day. This is here, me and Jose with our kids, the kids that were born at the time. Here with Lucia and Jose. This is my partners and students in Ethiopia. And kind of, I put the ones with the kids in there on purpose because sometimes making the personal connections also helps with the partnerships. So we're all humans. We all can connect on many levels. So that's it. I thanked everyone else like I thanked before. And I can take any questions, I guess.
Comments? Oh, wow. Let's go.
That was a really interesting talk, and I really appreciated your mentioning of mentors from 2 different settings. I was wondering if you could share maybe personal examples from your experience of having mentors from 2 different settings and the benefits to the mentees. What do the mentees learn from you or from Dr. Lucia, and how did that happen in your personal experience?
Yeah, I mean, I think all of the projects I've done, whether it's been here in Bello or in Valadares, have included, multiple mentors for the students. So having kind of the field mentor be the, whichever location you're in. But I know that the students have told me directly benefited from not only seeing some of the similarities, kind of seeing how research does have a lot of commonalities in many places, but also the approach, kind of having someone have a clinician approach from more of a bench scientist or epidemiologist. And I think, I think they're direct benefits from that, and the whole mentor-mentee relationship should be a team. I mean, and I hope that I've been able to kind of give back with when I've come down here and worked closely, especially with students. The first time I was here for a month, so I was able to mentor several FASE students, and I think that's important to have kind of the different views and the different, just because they're differences doesn't mean it's wrong or bad. And I think that the students really benefit from that, from learning that.
Last comment. One more comment? No? Okay, so thanks so much, Jessica. All right, so we are finishing here. And before we close the symposium, again, I want to thank you, Dr. Ricardo, and I want to invite him um, for a final message here. But I wanted to thank you two special groups of people here. So first, I want to thank my colleagues from the United States. And has been a great journey. 10 years is not a 1 day, 2 days, 1 year, 2 years. We are building a strong partnership here. So you are here and you are the proof that this is all real and concrete. So thank you so much and take back the message to your colleagues at Stanford, Emory, and University of Miami that we will have a great collaborators here that are really committed to improve and to get more and more connected with you. Thanks so much for coming down to Brazil, and hopefully you have a great year. And the second group definitely are the students. Thank you so much for you all for being so amazing. This 10 years started with you. And of course, the next 10, 20, 30 years will be about you. So I was a student one time. Dr. Ricardo always talk about his experience as a medical student. So the difference between us and you are just the years of knowledge, but thank you so much. You are the reason for this. So take advantage of this. You have a great groups here. So be involved in the project. Be excited to grow more in knowledge and also to share knowledge in Brazil. We need that. Brazil needs your help. Brazil needs people like you, like us. Thanks so much.
It's the perfect closer, right? He left me nothing to say besides saying the obvious. It was a great meeting. I think was an opportunity for us in FASE to show our concern for not just for healthcare, but for one of the most important parts of the medicine for us in Brazil, which is infectious disease. For myself, it's not my subject. My subject is ophthalmology, but today I invited this group to visit my lab. So I changed a little bit and showing what we were doing, and somehow what we do as researchers is the same thing, is the same methodology, is the same spirit of trying to collaborate with each other. We were joking when we are creating the Institute for Research on Wednesday, saying that the BBB in Brazil, maybe you don't know, but a BBB in Brazil is a project, a broadcast of people living in a house, and so they film everything. Is it the same name for you in English? No, you are in the closed house. I mean, it's a kind of the same exposure. But the joke was that we have we are joking that we have a symposium. Is it going to change? Is a global? What is the next slide? All right, it's a building bridge between brains, right? And José Antonio, thank you for leading this project. José Antonio, I have the pleasure to always have been trusting his work and his leadership and us in this project. I mean, it was a marvelous project, a marvelous program. I know it has been very intense for you visiting different hospitals. Today, the Consul of the United States, we're willing to visit, to see you in the afternoon, today or tomorrow. But it's great to say, I'm sorry, but I have no time for you. It's great. I'm sorry, ma'am, but unfortunately, they have no space in their agenda for tomorrow. But I hope you keep working. Our project is to open doors, if not doors, windows for our students to go to the States and enjoy. And Bernardo, hey, Alan, Aleph, and all of you going to the States and to have an opportunity. But you also have to create an opportunity for people coming and visiting FASEM. And you, the Atlética and they have to work on this project to make this thing happen. I always tell them that the medical school is theirs. They have to work in different projects to get the match with our fellows in the States. But again, hope to see you next year. And maybe we can do another one next year. Thank you very much. This is all.
Yeah, wow. Yeah, let's take a picture, everybody. So everybody in the front, one picture together. Vamos tirar uma foto juntos aqui, todo mundo. Vamos ver isso aí.